We're all good. So, my name is Jeff Grimm. For those who haven't met me, I've been with Theta Star for just about 24 years. So I think most of you have seen me at some point over the years. What I'm going to cover tonight is kind of a mixture of stuff for EMS and fire and everything kind of crossed over to both. First, I'm going to cover air medical utilization guidelines. These are going to be indicators for when to consider calling for a helicopter to an incident scene. Okay? Doesn't mean every time you call for a helicopter, somebody's going to need to be transported. One of the big things I'm going to focus on is early activation. And my point with that is, if you've got good dispatch information or dispatch information that tells you you might need this patient flown to a trauma center, cardiac center, whatever it may be, stroke center, get the helicopter going as early as possible. If you end up getting there, determine you don't need us, just cancel us. Not a big deal. We'd rather have you call early and cancel if you don't need us, then wait till you get on scene, and now you're waiting that extra time for us to get there. So earlier you can activate us, the better it'll be for you and for your patient. Okay? We'll talk more in depth about that. If you have questions as I'm going through, please stop me, get my attention. Okay? Next, after that, we're going to go to landing zone setup, safety around the LZ, and safety around the helicopter. Okay? So it's all just going to kind of run together. Hoping, looks like the weather's kind of moving through, so good chance we should be able to get the aircraft out here tonight unless they get called out. So they'll let me know if there's going to be any issues with that. But for right now, I'm anticipating they're coming until I hear otherwise. So, all right. So we'll get started. Please, if you have questions, just get my attention and we'll answer them at the time. It's much easier to address your questions as we're going through. So, first off, benefits. What's the biggest benefit of a helicopter? Speed, right? Just goes faster. That's really the biggest benefit. Yes, we have a highly trained team. We carry a lot of great stuff, but you know what? You got paramedics who can do a lot of that great stuff as well. Our biggest advantage is speed and getting those patients to definitive care. That's our primary job, is get that patient to the ultimate care they need, where they can get the treatment they need and get out of the hospital and back into the community. So, our aircraft travels about 145 miles an hour on average. Okay, this tells you the flight times to some of the areas around here. So Berlin's about a 12-minute flight time. To Green Lake here about 15, Princeton 17, Ripon 13 minutes. Okay, that's our flight time. In addition to that is the time it takes from the time we get the call to the time we go on route, which is usually right around 8 minutes. Sometimes a little less, sometimes a little more if we gotta do weather checks. That is why it's important to do that early call. That early call really makes a big difference. We can get that ball rolling earlier, and most of the time, you're gonna be on scene within that 6 to 8 minutes and have an idea if you truly need us or not. Okay? So please don't feel like you have to have gone and made a full patient assessment before you get the helicopter going. All right? We don't feel bad if we get canceled. All right? So just always want you to think forward. Do us a favor, if you want us, call through the comm center and have them call our dispatch center. One, it takes the load off from you. If you call on a cell phone, which then you're busy talking to us rather than taking care of the patient, etc. Also, going through the comm center allows everybody, so let's say it's a motor vehicle crash, allows everybody going to know what's going on, know that the aircraft's coming, because the comm center will take care of those notifications, will make sure the landing zone setup is responding, the fire department, whoever else needs to know. Just minimizes extra phone calls, all right? Just makes the process flow much easier. Radio contact we'll talk about in a little bit. If you think you have an incident where you need more than one helicopter. Let's say you have a multi-vehicle crash, multiple patients. You want 3 helicopters. All you gotta do is have comm center make one call to us, tell us what you need. We will take care of the rest. We'll take that load off from Green Lake Comm Center and take it on. We'll find 3 aircraft and we'll find you the 3 closest. And if there's not 3 that can get there quick enough, we'll tell you that as well. In other words, so realistically from here, your 3 closest off the top of my head would be us, Portage, UW Med Flight out of Portage, And then it's kind of a little between Flight for Life and Waukesha, and possibly, oh my gosh, LifeNet, the newest helicopter. But one, we found with LifeNet, it takes them a long time to get going right now. So we probably would lean more towards Flight for Life or UW out of Madison. But one thing we have in our CAD system is it tells us which aircraft are where and what their flight time would be to get to you. So we can, off the top of my head, I can guess, but our system will tell us exactly who's gonna get there and how long it'll take. The other thing we'll do is when our comm center calls them, for example, if the next closest is UW Med Flight out of Portage, we'll make sure that it's that aircraft coming. Whereas if the county calls and just says, hey, is your helicopter available to come, you might get the one out of Portage, you might get the one out of Madison, or you might get the one out of Mineral Point. So you gotta know what to ask for. So that's why we really encourage, and the most important part of this whole thing is really, if there's multiple aircraft going to a scene, to coordinate them through one site for safety. That way, everybody knows which aircraft are coming, where they're coming from, what their ETA is. We'll talk more about this a little later, but it's real important because we have air-to-air communications that we do with the other aircraft. So our pilot will talk to their pilots and we'll coordinate, and then we'll also coordinate with you guys on the ground to make sure that there's no problems as far as coming in and landing. So, and we'll get into that aspect of it a little bit later. So, first I want to talk about why do you want to call for a helicopter? What are the reasons, okay? Ultimately, I'm going to give you a lot of information. These are just triggers to make you think about it. The key that I want you to remember is not the specifics, but if you have a patient who needs to get to definitive care quickly, you want to get that going as quickly as possible. So, sooner you get that process going, the better it is. So, let's get into some specifics. So, general mechanism, revised trauma score less than 12. How many are paramedics in here? How many of you off the top of your head can recite how to do a revised trauma score? That's okay, most can't. I can't, really. You don't need to know. All you need to know, you know how to do a Glasgow Coma score? You know how to check a blood pressure and heart rate? You got what you need, okay? If any of those are unstable or not normal, their trauma score is less than 12. Okay, altered mental status, tachycardia, hypotension. Those are your key things, okay? Those patients are of a higher likelihood of needing trauma care at a trauma center. Major bleeding source that's uncontrolled, okay? In other words, you can't control by either direct pressure or a tourniquet, depending on where that source is, okay? And then unstable vital signs, which I pretty much covered already. Another major unstable vital sign I want you guys to remember, an early sign of shock, is respiratory rate. That actually, tachypnea, fast respiratory rate greater than 30, continuous, okay? Not breathing fast for a little bit, then calming down, then breathing fast and calming down. But a continuous respiratory rate greater than 30 is a very early sign of shock. So think of that also. If I sound congested, it's because we did water egress training today, so I practiced drowning. General considerations. Now these are all ones that are just more looking at the mechanism and general situation. These are not definitive. In other words, multi-system injuries, patient with injuries to more than one area of the body generally, okay? So if somebody has head and chest injuries, more likely they're going to have more need for surgical intervention or critical care, okay? Somebody who has chest and lower extremity injuries, for example, chest and femur, you have to assume that anything in between has potentially had enough energy to be injured as well, okay? Ejection from a vehicle, okay? Again, we've seen ejections that are fatalities, people ejected who are fine and walk away with minor to no injuries, and everything in between, okay? Just think way ahead. Pedestrian or cyclist struck by a motor vehicle or death in the same passenger compartment. Again, just higher index of suspicion because of the risk for the injuries, okay? Sorry, just looking, he said, pilot's going to determine whether a little closer to the time, just to be sure, so. We'll keep rocking until he tells me anything. Ground provider perception of significant damage. can see that picture there, car runs into a bridge abutment, that's significant damage, right? You can look at that vehicle, and when you have that oh shit factor, that's probably an indicator to maybe think about getting some more help there, okay? Especially if there's significant intrusion in that passenger compartment. Okay? Remember, energy's gotta go somewhere. The car absorbs some of it, eventually the patient's body is gonna absorb the rest of it, okay? So it goes through the car, then the body, and then the organs, okay? Penetrating trauma, abdomen, pelvis, chest, neck, or head, okay? Any of those core areas. Key is, we don't know how deep that penetrating trauma might be. I don't know if you've seen a lot of stab wounds. Stab wounds can really trick you, especially if the knife or whatever instrument isn't embedded in the patient. Somebody's been stabbed, they have a stab wound, let's say to the chest. I've seen some that look horrendous, they're bleeding like crazy, and they take them in, they check them, and it hasn't even entered the pleural cavity, okay? Other ones that look very minor, but it's gone in much deeper and creates more of a problem, so. I always say, I'm not the surgeon, not my job to figure out how deep it is, it's just my job to get them to somebody that can. Crushing injuries, pretty much of those same areas. Fall from a significant height. Adults about 20 feet, children 10 feet, but more importantly, 2 to 3 times the child's height. So, you know, counter like this and a 9-month-old baby that rolls off after, you know, being changed or something, that's a significant height, especially on a hard floor. So take that all into consideration, okay? Remember, kids aren't gonna, so kid falls onto a hard floor like that, they aren't gonna have fractures, most likely, but they might have underlying organ injury and soft tissue injuries. Glasgow Coma Scale score, less than or equal to 13. So essentially 2 points off your Glasgow Coma Scale, okay? Deteriorating mental status. To me, that is the most important thing when it comes to neurological exam. You have a patient who is at whatever level. Let's say they're a GCS 14, they're a little confused. And then 5 minutes later, they're a little worse. And then the next time they're a little bit worse, or they start repeating themselves and not making sense. Things kind of go downhill. They might not even go to the point of being unresponsive, but there's significant deterioration in their mental status. That tells you there's a mass effect going on. It could either be bleeding, or it could be edema in the brain. Either way, they need neurosurgical evaluation. Okay? Open or depressed skull fracture. How many of you have seen an open or a depressed skull fracture in the field? Okay? You don't see it a whole lot. You've probably all taken care of patients with skull fractures and don't even know it. Okay? My point with that is, if you can tell in the field that you have that skull fracture like that, that patient needs to get to a trauma center with a neurosurgeon as quickly as possible. Okay. Neurological presentation suggested with spinal cord injury. We all know what spinal cord injury looks like. The key is, let's say somebody has a full transection of their spinal cord at whatever level, T4, okay? Transection of spinal cord at T4. Are they ever gonna walk again? If it's completely cut? No. Are we gonna fix that? No. So why is it time sensitive? Any idea? Why am I telling you that's a good idea to fly that patient? What happens if you, let's say you just hit your arm really bad and you get a bruise. What does that bruise do over time? Swells, gets a little bigger. Same thing happens with spinal cord, okay? So that T4 transection can progress up to a T2 potentially. So that's why it can be the difference, you know, between somebody not walking and somebody becoming a quadriplegic, or somebody being a quadriplegic but still having shoulder and, you know, gross arm movement and being on a ventilator. That's why it's time sensitive in those such situations, to address that before that edema and that swelling of the cord makes it worse. Chest, thoracic considerations. Flail chest. How many of you have seen a flail chest in the field? A couple of you have. Okay. What's it look like when you see? You hear about it in class, right? What have you guys, when you saw that flail chest in the field, what did you see?
Oh, it just paradoxically moves it.
How big? Do you remember how big it was?
Oh, pretty
So a good half of the
Good,
chest
yeah,
probably, right? Yeah.
Nothing else was moving except for that.
Yeah,
big
that's
section.
suction. And that guy was probably having a really hard time.
Oh, yeah.
Yep. So, yours pretty similar?
Yes, I was.
Oh, same one?
Yes.
Oh, copycats, huh?
Well, not just Josh
Oh,
had,
same, but
I-
same
many years
type of
ago.
situation, yep. So the important thing to remember about that is what Josh just said, as you see that big section moving. You've probably all taken care of patients with flail chests and didn't know it. So what's the textbook definition of a flail chest?
The two or more ribs.
Two or more consecutive ribs broken in
Two or more locations.
two or more places, yep. So you have a free-floating segment. Now, you can each feel your ribs, right? If you feel two sets of ribs next to one another, they're not that far apart, are they? Now, if you have 2 or 3 ribs broken in 2 or more places, you're not gonna see that section moving, okay? Especially on a bigger person, but in general, because the air movement, the majority of air movement is the rest of the chest. But when it gets to be that bigger section, where it impedes their ability to breathe effectively, that's when you're gonna notice it, okay? So, what do we do to treat that patient when it's as bad as what Josh just described? What's the gold standard for treating that patient? What did you guys do with that patient?
We splinted it, stopped it from moving,
Okay,
held it in place, checked for pneumos.
was he awake and alert, breathing okay?
Yep, once we stopped moving, once
Yep.
it stopped the paradoxal movement,
Yep.
yeah, he started breathing a
So,
lot better.
what we have to do a lot of times with these patients, especially if they go into respiratory distress, and the key is to do this before they go into respiratory failure, obviously, is we'll paralyze and intubate and do positive pressure ventilation. What that does is it moves all that section together. So when you do positive pressure ventilation, the chest moves as one. Okay? Otherwise, every time that patient's breathing and that section moves like this, not only does it hurt like hell, anybody had a broken rib in here? Okay, not comfortable at all, right? So now imagine, like he's describing, 6 to 8 ribs in multiple spots, and every time you breathe, those are all rubbing. Okay, it's extremely painful. So one, you want to take care of their pain if at all possible, but now we got that fine line between pain and respiratory, depression, all that good stuff. Okay. The other thing to remember is every time those are moving, beneath every rib, there's a nerve, an artery, and a vein. So you're lacerating those every time. So you have pain and bleeding going on. So if we can get those all to move together, it makes a big difference. Okay? That's probably the most common major chest deformity. The other one would be a sternal fracture. If you've ever seen a patient with a sternal fracture, especially if it's in multiple spots, and that can do the same basic thing. Okay? The difference there is it's not just one side, it's in the center and affects the entire chest. Okay? Pneumo or hemothorax, you guys know how to treat a tension pneumothorax, right? So, first off, tension pneumothorax or tension hemothorax, same outcome essentially. What are your signs that the patient has a tension? Say again? Yep, absent or diminished lung sounds, okay. So, this is real important, and it's also important when you put an airway in. Where do you listen for those lung sounds if you're looking for a pneumothorax? Excellent. Go actually high axillary. The way I was taught years ago, get that stethoscope high and wet. Okay, if it doesn't come out wet, you weren't up high enough. Okay, get in the pits. Reason for that is up in the axillary, you're closest to that lung field and furthest from the opposite, so you don't get transition of sounds across. Okay. Makes a big difference. I've seen a lot of pneumothoraces missed because people listen up here. If you listen up here, you're hearing bronchial sounds, you're not hearing lung sounds. So if somebody has a completely collapsed lung here, you'll still hear lung sounds on both sides. Okay. So good, high and wet, okay? So diminished lung sounds, what else might you see if they have a tension pneumo? Okay, early, late, how many of you ever seen tracheal deviation? It's a very, very late sign. I've been in EMS for a little over 30 years. I've seen it 3 times, and not a single one of those patients had pulse. Okay. So yeah, it's a very, very late sign. So don't wait for that to happen. That's okay. Treat it before that. But it is a common sign. You might see JVD if they have good perfusion. Okay. But the most common is really those absent sounds the history, the story, and knowing, you know, that there's likelihood for impact. And ultimately, what are you gonna do to treat a tension pneumothorax? Needle decompression, okay? Have you guys, how many have done needle decompressions? Couple of you have, okay? Do you hear a big loud whoosh? No. Okay, it's not like they tell you in school, it's not like the book, you know, you'll hear a rush of air. No. It's a 14 gauge or approximately that size angio or similar. You might hear or something like that, but most of the time you don't hear anything. What you do get is if the patient's breathing independently, it's much easier for them to breathe. If someone's ventilating that patient, it's much easier to ventilate that patient almost immediately. Makes a big difference, okay? So my point with all that is if you think your patient has a tension pneumothorax, don't wait to prove it somehow, like the tracheal deviation or something like that. Treat it, okay? Because what do you create when you put a needle into somebody's chest? You took that tension and changed it into an open pneumothorax, okay? So if I would put a 5-inch 14 gauge angio on Josh's chest right now, he would end up with the same problem as if he had a tension pneumothorax and I fixed it. My point is nobody's gonna say you were wrong because you just fixed the problem. Okay, the outcome's the same, okay? This is where you have to trust your judgment as a clinician and go with your gut, okay? If your patient is a traumatic arrest, especially blunt trauma, I don't know how your protocol is, but the recommendation is bilateral needles regardless if you hear lung sounds or not, okay? If you're gonna work a blunt trauma arrest, you have to assume they have pneumothoraces and just put needles in. Then you don't have to worry about it at all when you're ventilating them, creating tension, okay? So. Hemothorax, essentially same basic thing, except your needle probably gonna do anything. They're gonna need a chest tube or finger thoracostomy. Do you guys do finger thoracostomy or anything like that? Okay. So we've done chest tubes for years. We just added finger thoracostomies into our protocols recently, and actually just a little over a week ago, one of our crews did the first one. They had a trauma patient arrest in flight, and we just did bilateral finger thoracostomies. Wasn't a good outcome. Blunt trauma generally isn't going to be a good outcome when you help them. Suspected cardiac injury, I'm not even going to go into that other than to say if you kind of rule everything else out, there's signs of MI or cardiac issues, there's potential for cardiac injury, especially if there's blunt chest trauma, okay? Really doesn't change anything you do. You're not going to fix a suspected cardiac injury unless they have pericardial tamponade. And my guess is you're probably doing a whole lot for that. But if we need to, we can do a pericardiocentesis. To be honest, it's very rarely done, and mostly it's kind of a last-ditch effort, especially in the field. Abdominal pelvic considerations. So somebody's got significant abdominal pain after blunt trauma. What's causing that pain until proven otherwise? Bleeding, okay? Significant abdominal pain is most likely one of two things. Either bleeding, which is a surgical emergency, because if they have blunt trauma in the abdomen, they're bleeding internally, can you compress that anywhere? No, nothing we can do to stop that. We can do things to help mitigate a little bit, but nothing we can really do to stop it. They need surgery, okay? The other thing that causes major abdominal pain in blunt trauma is rupture of a hollow organ, the stomach or the intestines, okay? Those rupture and those contents leak out. You can imagine that's gonna be pretty painful. That's gonna lead to sepsis, again, another life-threatening injury, okay? So either way, time sensitive, okay? Seatbelt sign or other abdominal wall contusion. So what's the problem with where you see that bruising on that patient?
Where's seatbelt forward?
Yeah, where bad. So what are his risks for injury? Okay, what could be injured in here from that? Say again?
Liver, spleen.
Yeah.
Intestines.
Intestines, stomach. What's the thing here that separates the abdomen from the chest? Diaphragm. Have you ever seen a patient with a ruptured diaphragm? That energy pushes in on the belly and just pushes that diaphragm and ruptures it, usually left side more than the right. So what happens now, that diaphragm's ruptured. Okay, you have the chest and you have the abdomen. They're supposed to be separate cavities. Now they're all one cavity. So all these organs here that are under higher pressure are pushed up into the chest. So what happens with your patient's ability to breathe? Their ability to perfuse. So, you know, Now, the other thing to think about with something like this, especially a skinnier guy or a child with that type, is spinal cord injury. That energy coming all the way through the spinal cord as well. Rib fractures below the nipple lines. You see obvious injuries below the nipple line, you assume it's both chest and abdominal trauma until proven otherwise because of that potential for anything. Pelvic fractures. How many of you have seen an open book or an unstable pelvic fracture in the field? Okay, like the head and the chest things, it's one of those things that when you see it, you know it, okay? So my point with these is we don't need to be radiologists, we don't need to have all the films and stuff. If you see it that bad in the field, that patient needs to get to a trauma center, okay? You're gonna have patients with pelvic fractures or hip fractures, etc., that are stable, perfectly fine. They don't need to be flown. But if you have that one that is open book fracture, you know, the motorcyclist who hits something and just splits their pelvic area wide open, okay? Unfortunately, the one where the girlfriend's riding with her feet up on the dashboard like this, they do some nasty damage, okay? But when you see that, you know it, okay? And those patients are gonna need some major care. If that pelvis is unstable, number one, don't move it any more than absolutely necessary. Do you guys have a way of stabilizing the pelvis if it's unstable? Or open book like this? Okay, and that's good. We carry a pelvic binder, but a blanket, anything you can do to stabilize that is important. Now I'm gonna give you a tip. Do you carry sheets at all? Like a regular sheet, something thinner than a blanket. The only reason I'm saying that,
Usually, but yeah.
not usually, if you have a sheet or something a little bit thinner, it's easier to secure it. And what you don't wanna do is you don't wanna tie it, you wanna just literally have cross it, wrap it around low. The key is the top of it should be at the top of the pelvis, okay, not on their abdomen at all. Wrap it around low, bring them in tight. Put one person on each side and pull that as tight as you can, and then clamp it somehow in the center. Because if you tie it, what's it gonna do? It's just gonna pull apart. So somehow clamp it, if you have a big clamp or whatever you can use to just secure that in the center. But anything, even if it isn't perfect, anything you can do to keep that pelvis from moving is gonna minimize bleeding. Remember, that pelvic cavity can hold up to 1/3 of that person's blood volume without you seeing a drop of blood anywhere. If they're hypotensive, you're ready behind the eight ball. Even more important to stabilize that pelvis as much as you can and get them to definitive care. Extremity considerations, orthopedics, okay? I know it's not pretty, but it's important. So, partial or total amputation of the limb, excluding digits. Really, for the arms, anything wrist and above is the ones that we're most concerned about. If it's digits, you have time, it's probably not life-threatening. However, if you have somebody has, let's say, table saw right through like this, and they cut their thumb and forefinger off, that's a little more time sensitive because if it's a clean cut, we can get them in and get that reattached, much more chance of returning function. Okay. Whereas if somebody cuts off their pinky, the chances are they're not going to do a thing about that. Okay. Because it's really not going to change their ability to function. Okay. They might have a floppy finger in their glove, but other than that, they'll be fine. Okay. However, something like this picture, so this is an auger type injury. Okay. Actually, it wasn't a farming; it was a manufacturing plant injury. Okay. And I'll be honest, I wasn't involved in this. I don't even know for sure the final outcomes on this one. But when I look at it, there's some important things that I think about. And it looks like the patient's laying on his belly, right? But he's not. Okay. So the patient's right leg on that side. If you look at that, you can see where his knee is right at the top of the picture. Okay. The key there is we may or may not be able to save that extremity. That's not up to us to decide, just like with the spinal cord injury. But what can make a difference is giving that patient a definitive care and might make the difference between a below the knee and above the knee amputation on both of those legs. Okay? Below the knee is much easier for somebody to recover from. Okay? Also, I mean, it looks horrible, but that right leg might be salvageable. I don't really know. It has twisted up, but if they can realign things and get blood flow going quickly, that might be salvageable. Okay, the left leg, less likely, okay? That's got some pretty significant friction injuries as well. But again, that's not my job to decide. My job is to get them to the person that can give them the best possible outcome. So that's where we all work together to do that. So, fracture dislocation with vascular compromise, you know, you can try to reposition a little bit once. But the key, again, get them to that orthopedic surgeon that can fix the underlying problem. Okay. Ischemia. So this, little different than just vascular compromise. This would be, for example, somebody's pinned between two vehicles, or pinned between a vehicle and a loading dock or a building or something like that. So their legs, let's say their legs are pinned right here. Could even be in a motor vehicle crash, legs are pinned here, okay? So what happens when your legs are pinned, okay? It's essentially a tourniquet, right? So depending on how tight that tourniquet is, just like we have tourniquets, we have venous tourniquets for IVs, and we have the real tourniquets for stopping bleeding, right? Well, if that is only a partial, it's only obstructing venous flow, what happens is all that arterial flow gets down into the legs. And you have venous stasis. The veins are collapsed, so you can't bring the blood back, okay? So over time, that blood that's pooling is essentially just gonna become toxic, okay? So what happens when you release that pressure? Have you guys ever had a patient like that, where you extricate them from a car or from something like that? They can be awake, alert, doing fine, and they'll go down just like that, okay? You really gotta be anticipating that, thinking ahead. Number one, get fluids going, be ready for resuscitation, and consider even putting tourniquets on before you take them out of that, so you prevent that from happening, okay? So that's a big concern in those situations. This is where, you know, really experience comes in. I know you guys have a lot of great experience down here, so that helps a lot. I've seen a lot of, and it's not put in, we all were brand new paramedics and EMTs at one time, but I've seen a lot of times in my career where the, yeah, he's fine, he's awake, I don't even know that we're gonna need you guys, but, you know, just in case. I had one where there's a head-on highway speeds, car entered an interstate type highway the wrong way, okay? So you're looking at 70 miles an hour for each vehicle head-on. Okay? Elderly guy in one vehicle, 16-year-old girl in the other vehicle. And the medic said, I really don't think we're gonna need you guys. You know what I said? Call a second helicopter. What? They didn't. Guess what? They eventually did. Because they were extricating both people, and the vehicles were, I would say, 200, 250 feet apart. So it's me and my partner, and then the paramedics that were there on scene. And two fire departments and two different vehicles extricating simultaneously. Well, guess what? They got them both out about the same time. So I literally have been staged in the middle, like whoever gets out first. Well, you can pretty much bet the elderly guy's gonna be the first one. Pulled him out immediately when it declared dangerous, almost within seconds, okay? So they're yelling, get over here, boom, 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 we start working him. No more than get to him, they get the girl out of the other car. Well, guess what? She was 16, she's healthy, she's fine. Guess what they didn't do before they took her out of the vehicle? No, seriously, they did nothing. No IV, no line, no nothing. Well, what do you think the chances were of getting an IV in after she was pulled from the vehicle? So my point is, it's not to put down anybody, so locationing doesn't matter. The point is, think ahead. Think, what next, okay? If this happens, what am I going to do to address it? What's our basic things they teach you in school early on? IV, O2, monitor. Just get it right away. I'd rather have an IV kept and never need it than not have one that I need. So that's really the reason I tell that story. Okay, open long bone fractures, 2 or more proximal long bone fractures. So when I say open long bone fracture, I'm not talking the gross, you know, arm ripped apart here and bone sticking out, or leg bone sticking out like this. If you have deformity fracture with open skin in the area, it's an open fracture. It's a direct source for infection. Okay, you use IOs. Okay, IOs work great, right? I love them. They work great, they get fluids in, everything, medications in quickly. Same concept though with an open fracture for infection. Becomes systemic infection very quickly. Okay? 2 or more proximal long bone fractures. So if somebody has bilateral femur fractures or bilateral humerus or one of each, why am I concerned about that? It's just broken bones. Why is that a potentially life-threatening injury? Any ideas?
Because bones can bleed.
Blood loss. So a femur injury can lose up to 500 milliliters of blood. This arm, 250 to 300 milliliters of blood. That's a significant amount of blood if you have 2 of them fractured. Okay? That's one part of it, and that's a very important part. The other part is if there's enough energy to fracture 2 of those bones, there's likely energy to injure something else internally. Now, could you imagine 2 femur fractures? Is that a distracting injury? Is your patient gonna say, yeah, my C-spine's tender, or yeah, I have abdominal tenderness? No, all they're thinking about is every time they breathe or move, that bone in their leg is hurting like hell, okay? So you really have to think about that distracting factor. Don't get focused on those, take care of them, but assess your whole patient, okay? Burns, greater than 20% of the body surface area, okay? Don't worry about getting perfect on measuring burn size. You know when you look at them that that's greater than a fifth of their body, it's significant, okay? Most importantly though is burns that affect the airway. Face, head, that area, any inhalation type injuries, okay? Even if it's minor burns and they have inhalation injury, you have to be aware of that potential airway loss, okay? Again, think proactively in those situations. Anything involving the face, head, hands, feet, genitalia, or greater than 20% of the body surface area is going to the burn center, okay? If we come here to pick up a burn patient, we're gonna go right down to Madison, pretty much every time. Unless weather's gonna prevent us from getting there, there's no reason for us to go back towards that way and then down anywhere else. If it's trauma in burn, they need to go to the trauma center, most important. Madison is both trauma and burn center, okay? That's why we're gonna go that way versus Milwaukee, plus Madison here is a little bit closer, okay? But if we have to choose, we're gonna go where they have both trauma and burn care capabilities, okay? Now if somebody has just straight burn injuries, you know, just like a flash fire, and there's no other injury involved, then they could go to a burn center like St. Mary's in Milwaukee as well. You can see the respiratory injury signs. Have you guys ever had patients with inhalation injuries? Okay. So some of them do just fine, and other ones will decompensate extremely quickly. Electrical or chemical burns. So I'm gonna talk chemical first, and just the most important thing I'm gonna say about chemical burns is protect yourselves. Okay? Know what chemicals you're working with and how to neutralize them if you need to. Okay? So how do you determine that?
SDS.
What's that?
SDS.
Yep, SDS, or if they have a let's say it's a vehicle that's leaking something, somebody got some on them. If they have a placard, you can use that emergency response guidebook. If you haven't done it, just load it onto your phone. ERG 2020, I think it is now. It'll give you everything you need in that type of situation. It'll tell you how to neutralize, tell you how to treat basic first aid for that patient, okay? And then finally, if you need to, go through your hospital or comm center and talk to poison control, okay? Or the burn centers. If it's a chemical injury, chemical burn, talk to the burn center, they'll tell you exactly how to handle it, okay? So yeah, a lot of different resources. Do you guys have a local or county hazmat team?
Kind of.
Kind of? Yeah, like a level 1 hazmat?
Yeah, we're not a level 1 anymore, we're a, more of a decon team now.
Decon team, okay.
But there's
But
still
they
a lot of.
probably have resources, and they can connect with like Oshkosh or something like that.
Oshkosh is our regional team.
Yeah, is your regional team. So utilize your, my point with that is, nobody is gonna know all the different chemicals. Utilize your resources, but if you don't know what your resources are in advance, you're not gonna know who to call. So, you know, kinda think about that in advance. Electrical burns. So if you look at this guy, you can see he's got burns kind of up by his shoulder here, lower back, and then on his buttocks. Not much for burns, right? He's fine, right? So what's your concern?
Everything in between.
Who said it?
Okay.
There you go. Yep, exactly. Everything in between, okay? And more potentially, because we don't even know what his feet look like, you know. So you have to assume everything in between is injured, not to mention the electrical effect on his cardiac conduction system as well, okay? So that is definitely a time sensitive, and that patient will need to get to a burn center as well. One of the biggest things, and I'm not doing a burn lecture or anything like that, I highly recommend, if you haven't done had somebody from a burn center come and talk to you, that you do that at some point. Talk to them about your burn protocols, have them look at your burn protocols and make sure that it's consistent with what they're looking for. Highly recommend contacting UW's burn center to do that. The biggest issue, feedback that we've gotten from them over the years is fluid volume resuscitation. People give them way too much fluid to burn patients. So they've really, you can use the Parkland formula, and that gets you pretty close, but they have other recommendations that they put as well. I'm not gonna go into that, I'm gonna leave that up to you to work with them, guys, but I highly recommend that you do that, because if patients with burns get too much volume resuscitation, it actually can make their outcomes worse, so. Near drowning is another one to consider, and we've had, it seems like the last few years, a lot more drowning type injuries. I don't know really if it's that it's happening more, or that we're just getting better at responding and resuscitating and we're end up transporting them. Regardless, we're seeing a lot more, and we're seeing actually better outcomes. The focus with near drowning type injuries, you know, they talk about CPR and early defibrillation, all this stuff. Drownings are totally different. Your focus is one thing: airway. Airway control, ventilation, and getting any water out of the lungs you can. So these are the ones that really an endotracheal tube makes the biggest difference. All right, a couple of quick general things. Consider air medical if just you're gonna use up your resource in area. You guys need to provide 911 coverage as well. Now that doesn't mean if somebody's got a twisted ankle and they're going let's say a fractured ankle, they're going for orthopedic surgery in Neenah or Appleton, that they should be flown. But if somebody meets the criteria, and it could be, potentially gone by critical care ground or by air, and you don't have any other resources in the area, utilize us to save your resources in the area. But if somebody truly doesn't need to be flown, I don't want them flown, okay? And it's not that I don't like taking care of patients, but I want to be available for the ones that are truly needed. You guys have run into it numerous times, I'm sure, where you call and we're busy, okay? I will say this, the majority of our calls are appropriate. We are less than a 2%, actually significantly less than a 2% over triage rate. In other words, of patients that are discharged from the ER, we're well below that. The national standard is 3 to 5%. So we're way below that. Other considerations: mass casualty, cardiac stemming cases, stroke cases, getting them to definitive care as well. So we'll talk more in this in just a second, but obviously for any call, we need a place to land, and that's where these other guys are going to come in handy. So we're going to talk about that now. Ultimately, we want to get as close as we can to the incident. So if it's at a motor vehicle crash somewhere, and we can land at or near the scene, great. Just keeps the resources all in one place. If there's not a safe place to go, then use a predesignated LZ, like right here. Okay? That's why we have the predesignated LZs. We know we have a safe place to go and meet you. Or, you got the patient ready to go and you have the resources to set up at the PDLZ, that's fine. Okay? And then we can also intercept at a hospital helipad, which we've done with you guys in those times as well. So, not going to go into it in depth. This is a lot of words, but ultimately this is the EMTLA law bypass for hospital helipad intercepts. So normally, anyone who works at a hospital knows that, especially in the ER, if a patient's on the property, that hospital is responsible for taking care of them, basically, right? This is one exception to that, and that is if that helipad is being used to effectuate helipad intercept for safety of the landing zone and patient and everything, okay? There's not a requirement, in fact, the hospital staff are not supposed to even come out to the ambulance unless they're requested, okay? The request can come from you as the EMS provider, can come from the patient or patient representative, or us as the air medical providers, okay? Now, if they come out, ultimately that EMTA law is triggered, and they're supposed to do their screening exam and all that stuff. But they threw another little exception into that. Really, so let's say you guys are at Berlin waiting for us to intercept, okay? And patient needs a procedure done, okay? Say they need an airway done. You're working on doing it, and the doc comes out and helps, okay? We all know how that goes, right? So doc comes out and helps. By law, that doc is taking charge and care of that patient. All they really have to do is write on a sheet of paper, I did this procedure, this was the outcome, blah, 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 sign it, and hand it to us when we come. That's all they have to do, okay? They don't have to do the whole transfer process, interfacility thing. That is one thing that they put in the EMTLA as an exception to that. So the goal is ultimately in those situations to minimize that time for definitive care. Those of you who worked in the hospital know that once that patient's in the hospital, that time to transfer is extended significantly because of all the things that have to be done, so. Not gonna spend time on this slide, but that's where all the trauma centers, level 1 and 2 trauma centers are in the state of Wisconsin, so. So, landing surface. Where do we need to land? Someplace relatively firm, flat, and free of debris. In other words, we don't want things that are gonna blow around and potentially hurt people, okay? Frankly, the debris isn't so much a problem for us as it is for the other people on the ground, okay? Obviously, we want to be free of overhead obstructions. Got to have a place to get through to get to the ground, right? So if there's trees and power lines crossing all over, probably not going to work well. So we need a relatively open area. Paved surfaces are the best, really work out well. Sod or grassy surfaces, second best. Packed gravel or soil, lowest level, that's about it. If you can get us on a roadway, a parking lot, something like that, it's gonna make everybody's job much easier, okay? Allows us to bring our equipment, not need extra help. We can roll our cot, etc. Whereas if we're off in a field somewhere, if that's the only safe place to land, by all means utilize it. But if there's the option to use a paved area, use the paved area. If we land in a field, we're generally gonna shut down everything because we're gonna need more help getting things to and from the aircraft, okay? Whereas if we're on a roadway or a paved area, we'll probably just stay running in most cases, get the patient and load them in and go. Maximum allowable slope is 5 degrees, relatively flat area, okay? Hopefully the aircraft's able to make it out here, but you'll see couple reasons for that. Our rotor system is what's called a rigid rotor system, so it doesn't tilt a whole lot. So if that aircraft, say this is the aircraft, and it's at an angle like this, well, the rotor system's at an angle. So we're not gonna get as much lift as we would if we were straight up and down. Okay? That's the most important reason for the slope area. Okay? Make sure I get the right button here. Landing zone size, minimum of 100 by 100. Now that doesn't mean that, so for example here, in your lot here, that blacktop area is not 100 by 100, but the total area around it is greater than that with the grass and everything, okay? It's okay if the paved area isn't 100 by 100. We just need that much total clearance, okay? So if we're landing on a roadway, for example, there's power lines and trees on one side. As long as the other side's open, there's plenty of room. And we don't even have to be in the center of that 100 by 100. We just need that much total space so we can have maneuverability and safety, okay? Bigger is better. If you can get 150 by 150 or bigger, you know, we'll never argue that an area for us to land is too big, okay? We like big. Ultimately, the final authority on any landing zone is the pilot. Okay? We know you guys on the ground, you can see what's in front of you, what you have there, and you know your area. But if we're coming in and we see something that doesn't look right and doesn't feel right to us, we'll let you know and say, hey, can we move the LZ to this location or to predetermined at the fire department or whatever it may be. Don't feel bad. It happens rarely, but especially at night, it's difficult to see all the things. So that's where we just have that overhead view. We can see a lot more. So sometimes we might say, hey, that's a little tight there, could we go on the other side of you, or could you expand it out a little bit or something like that, okay? Don't feel bad if that ever happens. So we wanna, where do we want the LZ? So let's say you have a motor vehicle crash out on Highway 23, okay? Crashes, head-on crash, vehicles are here, you have rescue vehicles all around, highway's totally shut down, okay? Now you're trying to decide, 23 runs east-west for the most part, right? So you're trying to decide, you want us on the east side or the west side of the scene? Let's assume both sides are wide open, plenty of space to land, okay? Here's how you decide. Look at the wind direction, okay? We wanna be on the downwind side. So let's say this is where the scene is. Winds are coming from this direction. Say winds are coming from the west, okay? We wanna land over here on the east side. So we're gonna come into the wind and we're gonna land before the scene. So we don't have to overfly the scene. Whereas if you put the LZ over here and we're coming and landing into the wind, we'd have to overfly the scene. Now you have a rotor wash affecting people and things like that. So think about the wind and put us on the downwind side of the scene if at all possible. Okay? Talked about this already, alternate landing zones. You know, and I didn't get a chance to look, other than the PDLZ here in this area, do we have any other predetermined LZs?
Marcus Ann has one.
Marcus Ann,
Princeton has one.
Princeton. And then the hospital at
Yeah, and then each one of the hospitals.
Berlin and Ripon, and then we can also use the football field at Berlin if we absolutely have to, especially if it's multi-year. That's kind of what I was thinking when I had, want to make sure. Kind of talked about this already, but approach departure path, we're gonna land and take off into the wind. Okay, we generally are gonna do a 2-to-1, so for every 2 feet we go forward, we come down 1 foot, opposite going out, for every 2 feet we go up 1, okay? We do that for a reason. Could a helicopter come in and just go straight down like this? Absolutely. But it takes a lot more power, especially coming out with the load and stuff, to do that. And the other thing it does is it puts us in a risk area much longer. So if we're coming in like this and we lose an engine, we have enough power and speed to maintain the land safely, or even go up and around and come back and land if we have to. Okay? Or if there's, and we've had this happen, coming into land and a vehicle comes, or somebody comes into the LZ. Okay? Doesn't mean that somebody's doing something wrong on the ground. People do stupid shit, right? Have you guys ever had a vehicle struck by somebody on the scene yet? Luckily, no? Good. But people, you gotta be aware, people are not paying attention. We'll talk more about that in a little bit, but coming in like this, we have much more option to, prevent catastrophe. Whereas if we were coming straight down like this, there's no way we'd be able to pull enough power without any forward motion to get out of that situation. So that's why we like having that clear approach path. Just another picture showing the approach and departure. Roadway LZs, have any of you guys from the fire department done the DOT time safety training for highway traffic management? Highly recommend it if you haven't. It's free. DOT will provide it to you for free.
Sheriff's Department's got an instructor for it.
They do? Okay, yeah, if you can get the training, for your fire department guys on traffic management, it's well worth it. I worked with the traffic incident management system in the state to make sure that the training is consistent across the state as far as helicopters set up on a highway. And ultimately, really, it's just block, so if you're landing on a regular highway, just block both ends where you want the aircraft in between, okay? If it's a divided highway, we'll talk about that in just a second here. Again, let's say we're on a northbound lane of a divided highway, close off that lane completely so traffic can't get through. Highly recommend that you close off the opposite side when the aircraft is landing and taking off. Why do I say that? Yeah, they're not gonna be paying attention to what they're doing. They're already watching the crash, and now you throw a helicopter in the middle of it. stupidity just went to the next level, right? So, yeah, exactly, he's got it right there. So that's why we highly recommend you just close everything off. Okay, now if it's a divided highway where you can't see the other side, not a big deal. I know that really doesn't affect you guys a whole lot, but, really think about the big picture. The other important thing I want you to think about, remember I said about a vehicle coming into the landing zone? The most, I don't even know if most recent, it does happen once in a while, but the most memorable one I have, we had crew coming into land, good LZ set up, they had the road shut down, both sides, did a good job. As they're coming in, a car pulled out of the hidden driveway right into they just didn't even realize, never thought about blocking off somebody's driveway, right? Pulled out right into the center of the LZ as they're on final approach. So they did a quick go around, fire department got that vehicle cleared out of it. It was a great learning, nobody got hurt, but it's just a good reminder. The crossovers on highways, make sure you control those. Any access point, you need to make sure you control, okay? Once that aircraft is on the ground, don't let anybody get near it, okay? If you need to get a vehicle through the LZ, let's say we've landed on the highway, and now ambulance is on the other side, and they need to get through with another patient or something like that, or some other vehicle needs to get in, contact us, contact the pilot, they'll be on channel, Mark II channel for the most part, we'll talk about that a little bit, and tell them what you need to do. They'll make the determination, either they'll shut down and help you guide that vehicle around the aircraft, or they'll lift off and fly around and come back and land after it's clear again, okay? But don't try to bring a vehicle through anywhere near that moving aircraft, okay? Multiple helicopter LZs, I talked a little earlier about, you know, if you need more than one helicopter, okay? So how are you gonna set up LZs for that? So every helicopter basically is gonna need a 100 by 100 foot area, okay? So whether it's a big field and you land multiples into that, or multiples on the road, or if you don't have a lot of room, you might put them in different locations or just rotate them out. So let's say you got 3 helicopters coming here, and the only LZ you have is right here. That's fine. First off, you can probably fit a couple helicopters here if you need to, if they're here at close to the same time. So we could do that. Or you bring the first one in, they get their patient, or let's say it's at a scene and there's a long extrication or something going on, they drop their crew, they move out, you bring the next one in, they do the same thing, and then you bring aircraft in as the crews are ready to go. There's lots of ways to do it, but that's why it's important that we all know who's coming and we coordinate through one site, so we can coordinate that as well. We'll talk with you guys on the ground about the landing zone and what's available, and then we'll coordinate between aircraft on how to best do that. And we'll communicate that to you. So ultimately, there's no good answer on exact, you know, do this every time. It's what works best in the situation, okay? And that's where we all just work together to figure out the best answer. Okay? Kind of talked about this already. If you need to, you can do sequencing of landing. This incident, some of you might remember, it's probably 15 years ago already, was a bus crash in Adams County. Semi ran into the back of a school bus that was loaded. I don't remember exactly, it was Adams County, I don't remember exactly where offhand, but we had 5 aircraft respond to that scene. And this is us landing, actually it's us taking off, I'm sorry. Spirit was in first, that's when Spirit was in Marshfield. They were in first, we were the second aircraft. The aircraft on the ground is Gunderson Air, Medlink Air out of La Crosse at the time. They were on the ground as we were taking off, and then there was 2 other aircraft still inbound yet at that time, so. But again, it just comes down to coordination. Landing zone markings. Don't use caution tape, like, you know, that tape stuff, the fire line tape, things like that, okay? It's not gonna damage anything or hurt anybody, but no matter how well you think you have that secure, that rotor wash is gonna tear it, and the potential is for it to get entangled in something, okay? For us, yeah, likely it's gonna cause damage, but if it impacts any of our rotor blades, we're out of service until a mechanic inspects them. So that's really what it comes down to. LZ must be clearly marked. I will tell you this, it's much easier for us to find an LZ during the night than it is during the day. Okay, lights are easier to see. You can see the lights, where they have them marked, all this stuff. During the day, the best thing you can do for us from the fire department side is tell us where the LZ is compared to the